So I find Radlink extremely helpful with PAOs, particularly to be able to judge the correction that we've done. And I've been using it about 4 years and have come to heavily rely on it. We did pretty good before trying to adjust the position of the fragment, but we had to sort of guess at what was the best pelvic tilt. And the great thing about Radlink is, one, it gives us an AP pelvis that we can do measurements when we provisionally fix the fracture. And two, we can measure the PSSI index, which will tell me the pelvic rotation or pelvic tilt, so I know my acetabular version is maximized. Because if I have under tilt or over tilt, it might mess up the relationship of my anterior and posterior walls. So the first thing I do with Radlink is when I provisionally fix the fragment, I will move the C-arm to mimic the standing AP pelvis or standing EOS. We measure the PSSI index, which is we want to get the same index on the table, even though they're supine, as we get in the standing view. And then we'll check our acetabular version that way, making sure anterior and posterior walls are in a good place. And then we'll measure our lateral sedge angle. Because sometimes you think you have it corrected and it might not be enough, or sometimes it looks like it's covered and concentric, but you overcover it, especially in the revision cases or those with severe, like today we had a case of EDS. I was okay to give a little bit more correction because she's very unstable, even with a mild dysplasia. So the benefits of it is when we're done, making sure we have good acetabular version, which we've been able to show post-op at 6 months is the same as pre-op and intra-op. So we did a study, we did it during COVID actually, where we took a group of patients and did a group that had Radlink and a group that didn't have Radlink. And we were able to show, first, our LCE divergence was a lot less. It was a little tighter with Radlink because you can almost dial in by the degree what you want to get. And also what we found is our pre-op standing, our intra-op pelvic tilt or PSSI index, and our 6-month post-op PSSI index were very similar. So you have confidence that what you're getting is what you're going to see when they're 6 months or 1 year post-op. So it gives me a sense of it gives me a sense of comfort that I have the acetabular fragment maximized as much as possible. And I can do it with an AP pelvis and do it with fluoroscopy. Particularly, like I said, acetabular version and lateral center angle and tonus angle. And then I can see really what the medialization is on a true AP pelvis, because you take 3 views or 4 views across the pelvis at 5 millimeters or 5 centimeters apart, and it stitches together a true AP pelvis that we can do measurements. As I said, I've been using it about 4 years now, and the study showed that it was a little bit more accurate in our corrections than it was before. It's really easy to use and user-friendly.